So to begin with, we'll study how hemostasis occurs. By hemostasis, we mean the physiological process that happens whenever there is a vascular injury and it stops the bleeding while at the same time maintaining blood flow to the rest of the body. So, hemostasis occurs in three coordinated phases. The three steps include primary hemostasis, secondary hemostasis, and tertiary hemostasis. So, in primary hemostasis, the final product is a platelet plug, a primary platelet plug that is formed. In secondary hemostasis, this primary platelet plug is reinforced by the coagulation cascade by forming fibrin over this plug, leading to the formation of a stable fibrin clot. In tertiary hemostasis, this clot is further resolved, leading to uh, leading to its resolution and restoring the blood flow and continuity of the blood vessel by processes of repair and resolution. So let us first discuss primary hemostasis, as to which is the process which involves the formation of the primary platelet plug. So, whenever there is a vascular injury, as a first response, vasoconstriction happens at the site so as to limit the blood loss that is going to occur. Also, at the same time, because of endothelial injury, the subendothelial collagen and the von Willebrand factor present on this collagen is exposed to the flowing blood. The platelets, they recognize this exposed von Willebrand factor and adhere to this von Willebrand factor using glycoprotein 1b, forming a von Willebrand factor and glycoprotein 1b complex. This activates the platelet and it will go on to release ADP, thromboxane, serotonin. These hormones would recruit more platelets to the site, and these platelets would aggregate, that they will stick to each other by by the receptor, which is the glycoprotein 2b3a. Glycoprotein 2b3a on two adjacent platelets will be joined together by fibrinogen. And all this platelet activation and aggregation at the site of injury will lead to the formation of a primary platelet plug. However, this primary platelet plug is highly unstable and it can be torn away by sharing flow of blood that is happening in the blood vessel. This unstable platelet plug can be washed away. So we need to form a stable platelet plug, which is a stable fibrin clot. We'll see how that happens when we discuss secondary hemostasis. Let us first go ahead and see a diagrammatic representation of formation of a primary hemostatic plug. So here on the left side of the diagram, you can see that at the site of injury, platelets are aggregating and they are trying to adhere to each other, forming a primary platelet plug. And we have a magnified view of what is happening at the microscopic level, where in the exposed collagen, the von Willebrand factor has been exposed. This von Willebrand factor is binding to the glycoprotein 1b on the platelets. Now, this platelet gets activated and it will release ADP, thromboxane A2, and serotonin, and this will bring together other platelets, and the other platelets will aggregate with this platelet with the help of glycoprotein 2b3a complex, and these two complexes on two adjacent platelets will be joined together by fibrinogen. So coming back again to the left side image, many of these platelets will aggregate at the site of a vascular injury and form a primary platelet plug. Now we see how the body goes on to strengthen this primary platelet plug by depositing fibrin over this plug. So at the site of the injury, vasoconstriction has happened. Platelet comes and adheres to this site and aggregates other platelets, forming a primary platelet plug. In secondary hemostasis, there is formation of the secondary platelet plug. On the primary platelet plug, fibrin comes on and deposits and forms a secondary platelet plug. So here the coagulation cascade, what we know already as the intrinsic pathway, the extrinsic pathway, and the common pathway, they will go on, which is known as the coagulation cascade. This will go on to generate fibrin, which is the end product of it, and it will cross-link the primary platelet plug and forming a stable fibrin clot. This stable clot will be resistant to shear forces and it cannot be washed away, and this will lead to strengthening of the hemostatic process. So The coagulation cascade is a series of proteolytic activations amplifying and culminating in thrombin formation. Thrombin is the final enzyme which causes conversion of fibrinogen to fibrin, and we want the deposition of this fibrin over the primary platelet plug to form a secondary platelet plug. So, all of the coagulation cascade pathways, whether it is the intrinsic pathway or the extrinsic pathway, will culminate in the formation of thrombin. This thrombin will convert fibrinogen to fibrin, and this fibrin will stabilize this primary platelet clot. So there are two pathways by which coagulation cascade can be activated. So these two pathways, as we all know, are the intrinsic pathway or the extrinsic pathway. In the extrinsic pathway, the vessel injury exposes the factor 3, which is the tissue factor. This factor, along with factor 7, will go on to activate the factor 10. Factor 10 is the factor at which both the pathways culminate and the common pathway begins. So in the intrinsic pathway, the contact activation starts with factor 12, then to 11, then to 9, then to 8, which will go on to activate the factor 10. Now, in the common pathway, factor 10 will convert prothrombin to thrombin, and thrombin, as we have already discussed, is the key enzyme which will convert fibrinogen to fibrin, will cause cross-linking of fibrin, and this will also further amplify this cascade by activating factors 8, factor 11, and factor 5. So here we have the extrinsic pathway in orange, the tissue factor, which was the factor 3. This, along with the factor 7, forms a complex which goes on to activate the factor 10. Factor where it's written factor XA, that is the activated factor 10. This will convert prothrombin to thrombin. Thrombin will go on to convert fibrinogen to fibrin, which will lead to the formation of a fibrin clot. Now, if we consider the intrinsic pathway, the pathway starts with the activation of factor 12, which goes on to activate factor 11, which then goes on to activate factor 9, then factor 8, then factor 9 and 8 complex activates the factor 10, and from there on the pathway is similar to what we saw uh, previously. Now we have a stable clot that is formed. However, in the body, once this hemostatic process is complete, we want that the clot should break up and it should resolve and final vessel healing should happen. So that process is known as tertiary hemostasis, where we will clear up this clot, and fibrinolysis will happen because we cannot afford to lose this blood supply to the through this blood vessel wherever this blood vessel is supplying. So the final step in this hemostatic process is fibrinolysis, which is the resolution of this clot. So how does this happen? Is that fibrinolysis will be activated. The endothelial cells, once they've been repaired, they start releasing the tissue plasminogen activator. Plasminogen activator, as the name implies, it converts plasminogen to plasmin. Plasmin is the main enzyme which is responsible for degradation of fibrin. It degrades fibrin into fibrin degradation products, including the D-dimer. The D-dimer test that we usually do, it estimates the fibrin degradation products. So, as we saw, the main enzyme for forming fibrin was thrombin, and the main enzyme for breaking this fibrin is plasmin. So then there is a regulation. We have the plasminogen activator inhibitor, which inhibits the TPA. Also the antiplasmin, which directly inhibits the plasmin. And once the vessel is repaired, the clot dissolves and the blood flow is restored. The tissue process, by the way of fibroblast endothelial proliferation, this would go on to complete the healing. So here we have a diagrammatic representation of the fibrinolytic pathway. Here plasminogen is being activated to plasmin, the active form, by the tissue plasminogen activator. The tissue plasminogen activator is secreted by the endothelial cells. It will go on to degrade fibrin to fibrin degradation products, restoring the vessel integrity. Now, we have seen how this hemostatic process occurs. What is the normal physiology of the hemostatic process? Now we'll see how do we normally evaluate the physiology of this hemostatic process in our body. So the few tests that you across PT, the prothrombin time, the INR, this is the international normalized ratio, the APTT, activated partial prothrombin time, fibrinogen levels, T timers. Then there are a few special cases like the case of a factor 10A assay and a thromboelastography. These are the commonly used tests in surgical practice. However, if we were to talk about the comprehensive list of all the tests that should be used, these would also include bleeding time, platelet count, a peripheral smear of thrombin time, a mixing studies, platelet function tests, and specific factor assays. Uh, we will not be discussing these tests because these are not so commonly used in surgical practice day to day, so day to day screening. These are the tests we are more familiar with, and these are the tests that we more commonly use to assess these the functions of the disorders in coagulation that we would come across in trauma and in surgical practice. So these are the tests that we are going to be discussing here. So, as a general overview, you can take it that the extrinsic pathway is studied by the PTINR, the intrinsic by the APTT. Fibrinogen evaluates the common pathway. The thromboelastography or the rotating thromboelastometry is used for whole clot assessment, and D-dimer assesses the process of fibrinolysis. Now, we'll discuss prothrombin time and the international normalized ratio in a little bit of detail. So, this measures how long it takes for blood to clot after adding the tissue factor into a sample of anticoagulated blood. So, this tests the extrinsic and the common pathways. And the normal prothrombin time, the level varies between laboratories and is usually between 11 to 15 seconds. So, what are the cases where prothrombin time can be prolonged? It can be prolonged in cases of vitamin D deficiency. We know that vitamin K is important for gamma carboxylation of the vitamin K dependent factors, which are factor 2, factor 7, factor 9, and factor 10. And these are the factors which are the factors of the extrinsic and the common pathway. So, where we have deficiency of vitamin K and a consequent deficiency of these factors, prothrombin time can be prolonged. Then in liver disease, this can be prolonged because the clotting factor synthesis is affected. In warfarin therapy, because warfarin blocks the gamma carboxylase and does not let vitamin K act, so it is a vitamin K antagonist. Then again, in these cases, prothrombin time is prolonged. And in disseminated intravascular coagulation, where there is a consumption of all the clotting factors, and for because of the deficiency of these factors in the extrinsic and the common pathway, along with those of the intrinsic pathway, uh, the prothrombin time is deranged. The INR is the international normalized ratio. It is the standardized version of the prothrombin time, which helps us compare the results across labs because the value of prothrombin time varies as per the lab and the reagents that they are using. So that is why we use INR to standardize the value across the world. So the normal INR is to the range of 0.8 to 1.2. And we are using it because prothrombin time varies depending on the reagents and the lab. Now, what are the uses for PTINR? It can measure the extrinsic and common coagulation pathways. It is used to monitor warfarin therapy. It can be used to assess the synthetic function of the liver, evaluation of vitamin K deficiency, and helps to evaluate coagulopathies or preoperative bleeding risk in selected patients. PTINR is not a test that is routinely done in preoperative evaluation, and it should be used selectively. Now, we'll discuss what is activated partial prothrombin time or APTT. So, this measures how long it takes blood to clot after adding a contact activator. This tests the intrinsic and the common pathways. The normal APTT ranges from 25 to 35 seconds. We compare the normal value with that of the patient value to know whether the APTT is deranged or not. So, when can it be prolonged? It can be prolonged in factor deficiencies such as in hemophilia A and hemophilia B, von Willebrand disease, when we are using unfractionated heparin, in cases of lupus anticoagulant and antiphospholipid antibody syndrome, and in severe liver disease or DIC. In DIC, all the factors are consumed. It's a consumptive coagulopathy. So all the coagulation factors are consumed, including those of the extrinsic pathway, those of the intrinsic pathway, and the common pathway. So in a case of DIC, the platelets would be low, APTT would be raised. Also, the PT-INR would also be raised, and there's extensive fibrinolysis also, though D-dimer is also raised. Now, what are the uses of APTT? It can be used for screening of intrinsic and common pathway defect, for monitoring of anticoagulant therapy. It is useful for unfractionated heparin. However, we cannot use it for low molecular weight heparins or direct oral anticoagulants. So low molecular weight heparins examples being enoxaparin, or commonly comes under the brand name of Clexane, and the direct oral acting anticoagulants. Again, these are two types. The first one is a direct factor 10A inhibitors, and then a direct thrombin inhibitors. Direct factor 10A inhibitors, the examples are apixaban, rivaroxaban, whereas direct thrombin inhibitor, which is the factor 2A, the example is dabigatran. So for selective preoperative and diagnostic screening, especially if there's a history of bleeding which is present, APTT can be used just as is the case for PT. These should not be routinely used but selectively used. So again, in this table, we have summarized the pathways that are assessed by these tests and the drugs that are monitored. It's an important point to remember for clinical rounds also and for exams also, as to which test can monitor, which drugs require monitoring by which tests. So warfarin requires PT-INR monitoring. Unfractionated heparin requires APTT. PT-INR and APTT are unreliable tests when we talk about low molecular weight heparins, fondaparinux, and direct oral anticoagulants. Low molecular weight heparins, the examples include enoxaparin, which is also known as Clexane. So this cannot be monitored by either PT-INR or APTT, nor does it derange either of these two parameters. Then, if we have to, usually with low molecular weight heparins and direct oral anticoagulants, we do not require monitoring. There are very few cases, such as renal impairment and pregnancy, where a monitoring may be required. And when we do need this monitoring, we have to perform anti-factor 10A assays, which will measure the factor 10A inhibition by these drugs. And there are some specialized assays, especially for dabigatran. You have to use an anti-factor 2A assay or a dilute thrombin time test. These are rarely required because most of the time these direct acting oral anticoagulants do not require monitoring, only in very special conditions. And when they do require monitoring, we will need to do a drug specific assay. So for low molecular weight heparins and direct acting oral anticoagulants, we do not usually perform monitoring. PT-INR is used for warfarin, and APTT is used for monitoring unfractionated heparin.